the Executive Vice President of the Maine State Chamber of Commerce. Our program this morning is brought to you by the Maine State Chamber of Commerce with the assistance of our sponsor. Our premier sponsor is Anthem Blue Cross Blue Shield in Maine, Cross Insurance, Martins Point Healthcare, Maine Health, Northern Light Health, and the University of New England. And we want to thank them all for their support. We have a large number of folks at our forum, participating in our forum this morning. And so we've got you all, you'll notice, muted. Folks will remain muted throughout. However, we are going to, at the end of the presentations, leave time for questions. If you have questions, you can feed those into the chat button, which is at the bottom, approximately center of your screen. And we will get back to those questions at the end of the program. We have a great lineup for you this morning of folks to talk about what happened in light of the current COVID-19 crisis and what happened in the legislature this last legislative session. I'm going to introduce all our speakers at once, and I will introduce them in the order in which they'll be speaking this morning. And we're going to begin with Denis McDonough, who is the president of Anthem Blue Cross Blue Shield in Maine. She is responsible for the management of Anthem's local commercial group and individual businesses, and for collaborating with elected officials, regulators, providers, and employers to improve access, quality, experience, and affordability in Maine. She has more than 25 years experience in the health insurance industry. She began her career at Harvard Pilgrim. She joined Anthem in 2010 as the director of sales in New Hampshire, and she was promoted to regional vice president of sales for the New Hampshire plan. She is very active in community. In fact, she serves as a member of the Maine State Chamber of Commerce Board of Directors. She has a bachelor's in English from Boston College and a master's in business communication from Emerson. Eric Chapa is the superintendent of the Maine Bureau of Insurance. He began his career with the Bureau in 1988, and he served as supervisor of the workers' comp section in the Bureau prior to becoming the deputy superintendent in 1998. During that time, Eric and I worked closely together on a number of workers' comp issues. He was confirmed as the superintendent in 2010, and again in January of 2017 to another 5-year term. Eric served as the president of the National Association of Insurance Commissioners, NAIC, in 2019, and he's currently the vice chair of the NAIC Financial Condition Committee and the vice chair of the Financial Stability Task Force. Eric has a BA from Potsdam State University and an MBA from Clarkson University. Christine Ossenford is a senior director of government relations at Anthem Blue Cross and Blue Shield in Maine. She represents Anthem before the legislature, the governor, state agencies that include the Bureau of Insurance. She is a graduate of Vassar College and of Syracuse School of Law. Prior to joining Anthem, Christine served as the senior governmental affairs relationship at the Maine State Chamber of Commerce. I see her smiling. And before that, she was special assistant and the legislative liaison for the commissioner at the Maine Department of Professional and Financial Regulation. I want to thank all of you for joining us this morning, and we appreciate and look forward to your presentation. And with that, Denise, I will hand it off to you.
Great, thank you, Peter, and good morning. Thank you all for taking time to join us this morning, and to the Chamber for organizing this forum and bringing us all together. As Peter mentioned, my name is Denis McDonough, president of Anthem Blue Cross and Blue Shield here in Maine. I also serve on the Chamber board and have had the opportunity to connect with some of you, whether it's through the Chamber, our customer relationships, or our work in the community. As some of you know, Anthem is headquartered in South Portland and has been providing health benefits coverage for more than 80 years in the state. We've got nearly 700 employees here in Maine and 70,000 across the country as part of our parent company, Anthem, Inc. Anthem's doing a lot of exciting things to help lower healthcare costs here in Maine, but before I get into those strategies, I wanted to touch on how we've been responding to COVID-19 since we know it's top of mind for all of you. So Angie, if you could advance to the second slide, please, for me. First and foremost, Anthem is committed to serving our members, our associates, and our communities during this unprecedented time. Our primary focus is keeping our members healthy by ensuring that they've got access to care, which includes providing testing and treatment for COVID-19 at no member cost share. Since the crisis began, we've been working closely with the Bureau of Insurance to find opportunities to further expand access to care in ways that keep our members safe. So, for example, before a directive was issued to do so, Anthem had made the decision to cover telemedicine services at no out-of-pocket cost for the member, as well to continue our policy of reimbursing our providers at the same level we reimburse for in-person visits, as opposed to a reduced level of reimbursement, thereby keeping the provider whole for that service. And while telemedicine is something that we've covered for years, it was not previously something we saw high utilization of. However, since COVID-19 struck, telemedicine has become a really safe and effective way for members to access care. So given that, in addition to removing cost shares associated with telemedicine during COVID, we've expanded the type of visits and treatment that we cover through telemedicine by covering services such as physical therapy, speech therapy, occupational therapy, because we know that people still need access to these services, but want to do it in a low-risk way, which telemedicine allows for. It also allows the provider the ability to deliver care that they would not otherwise be able to provide in person during this time, and would cause even further financial strain that providers are currently experiencing. So as a result of these efforts, we've seen a dramatic increase in the number of telemedicine visits over the last couple of months, which we view as a very positive thing. We also recognize that mental health is critical to a person's overall health, and that this pandemic has further highlighted the need for support around access to behavioral health treatment. As a result, we've tried to ensure that our members know that behavioral health services can be accessed through telemedicine at no cost share, and we've developed some new resources in partnership with some leading community and health partners to bring awareness to that. A few examples include a special campaign called Me Minutes, which promotes taking the necessary time for self-care and well-being. We're supporting the National Alliance on Mental Health, which creates awareness events and national virtual walks. And as a final example is a partnership we have with Aunt Bertha, a leading social care network that helps to connect individuals and families to free and reduced cost social services in their communities. In terms of our efforts to support our customers, we know that COVID has had a dramatic impact on our customers' businesses and their revenue. And consequently, we've been working with them to provide flexibility with premium payment and grace periods. We've also relaxed our guidelines in order to allow furloughed and temporarily laid off employees to stay on their employer group plan, provided the employer continues to pay the premium for the employees. Additionally, we've been evaluating the impact of COVID-19 on our claims costs with social distancing and delayed elective procedures and alternative access to care that have been put in place during this time. We've observed a temporary reduction in overall claims cost. In order to pass some of that temporary relief through to the employers and members as they're navigating the impact of COVID-19, Anthem will be issuing some premium credits to our small and large group fully insured customers. We're finalizing the details of that, but these credits will likely appear in their August bill and applied as a credit to their April premium. So more detail to come shortly on that. With regard to COVID testing and helping to provide access here in Maine to fill a need for more testing options in the greater Portland area, we worked quickly with a partner named Convenient MD to open a COVID-19 testing site in the parking lot at our South Portland office. The site was open for the month of April and tested several hundred people. And lastly, as it pertains to my comments regarding COVID ID, Anthem is actively working with and supporting our local communities during these unprecedented times. We've made over a $350,000 commitment here in Maine to help multiple nonprofit organizations address issues like food insecurity and other immediate COVID-19 relief, such as access to PPE. And nationally, Anthem Incorporated has contributed over $50 million to community organizations nationwide. Angie, if you could Proceed to the next slide, please. So moving into sort of our non-COVID related work, I guess I'll just start by saying, first of all, in spite of this crisis being an enormous area of our attention and focus, we're not letting it deter us from fulfilling our mission of improving access to high quality healthcare and reducing healthcare costs for Mainers. Our efforts and our strategies around achieving that goal have not stopped during the pandemic. And while the crisis has certainly had some very grave impacts to our world and our local communities, it has also afforded us some important learnings that I think will be very helpful moving forward. It has shown us that we can be more agile in the face of rapidly evolving situations, and that there are better ways for payers and healthcare providers to safely deliver care, improve access, and address health equity. The use of telemedicine and telehealth is one example that I touched on earlier, and has shown us a clear path to scaling cost-effective ways for the safe delivery of care to those who need it. We've also used technology in other ways to make it easier for providers to manage resources and capacity. An example of that is the rapid deployment of a COVID-19 symptom checker on Sydney Care, which is an application powered by artificial intelligence. Providing access to care is always front and center of what we do. And while we are extremely focused again on COVID-19 response and recovery, we continue to work with our customers, our provider partners, and others to develop and implement solutions to provide access to affordable care. So let's dive a little bit more deeply into that. I know it will come as no surprise to any of you when I say that healthcare affordability is one of our biggest challenges that we face as a nation, and Maine is certainly no exception to that. We have some of the highest healthcare costs in the nation here. We're the oldest state, and we have one of the lowest average incomes in the nation. So why is that, and what is Anthem doing about it? The traditional fee-for-service payment system is frankly broken. It doesn't work because it rewards providers for volume and not for value. And by value, I mean both cost and quality. We have historically paid on the volume with little focus on payment for quality and outcomes. And as the entire country is fighting these unsustainable medical costs, the only way to address it is to fundamentally change the payment system. So Anthem is working quickly to accelerate growth in these value-based payment models where providers are rewarded for cost and quality, including outcomes, care experience for our members, coordination, rather than simply volume. And what that means is moving to what we call a fixed payment methodology, when we pay a single set fee for an entire service, not unlike how Medicare reimburses providers, but at a higher level. And instead of paying sort of a la carte for individual components of a given service, we pay for the entire service. So for example, you pay one price for a sandwich, not the total separate itemized charges for the bread, the meat, the cheese, the lettuce, the mayo, etc. It also means paying providers for things that we didn't previously pay for, like creating care management programs for their more seriously ill patients, for extending coverage availability to the providers to reduce ER visits after hours. Hospital consolidations also represent a challenge to helping control healthcare costs. And while there can be very valid reasons for consolidation, studies in our experience have shown that these mergers can ultimately raise prices in most cases. We're building out high-performance networks across the country, featuring our top providers who agree to be accountable for delivering high-quality and cost-efficient care. We also believe that not every service should be provided in a hospital setting, and we continue to see a shift away from hospital inpatient settings to outpatient settings as we continue to help our members identify the right setting for their care. Many services do need to be rendered in a hospital setting, but many do not. So getting the member the care they need in the right location is critical to both controlling costs and keeping members safe, particularly in times like this. And as a result, we're supporting providers who provide appropriate services outside the four walls of a hospital when appropriate, where the cost can often be 3 to 4 times higher. Examples for those services would be things like lab, day surgeries, imaging, and infusion. And we've worked with providers, some independent, some hospital-based, to expand those services outside of the hospital for our members to be able to access care, including things like infusion therapy. As mentioned, we're using telemedicine to increase access and provide care that is needed in an alternate setting to urgent care and other sites, which is critical now more than ever. Angie, if you could proceed to the next slide. Thank you. So given the high cost of healthcare, the disparity in cost amongst providers, and the fact that our members have significant financial out-of-pocket exposure through deductibles that now average $3,000 per member, it's critical that we provide them with the tools and the information they need to make informed decisions around where they access care. We simply can't expect our members to make informed decisions without that information. So for example, Anthem members can use our transparency tool to find a doctor, to find a hospital, to estimate their total costs for specific services, as well as to find many things about their own benefits, where they are year to date, et cetera. We also create plan designs where member cost shares reflect the value of a service. For instance, a lower cost share service when rendered at a lower cost facility. So these plans empower the member to make informed decisions. Nothing is mandatory. They make the decision about where they want to go, and their cost share is reflective of the cost of the service and where it's rendered. We're building out high-performance networks across the country featuring top providers who agree to be accountable for delivering high-quality, cost-efficient care. In addition, here in Maine and some of our other Anthem states, we've implemented a Smart Shopper program, which gives financial incentives to members when they voluntarily choose high-quality, lower-cost providers. We offer technology to our members through an application called Sydney that gives them the data and tools to make these types of decisions around their healthcare. And as I mentioned, they can find their providers and their claims costs and their cost shares, et cetera. As we've shown in our ability to rapidly develop a COVID-19 symptom checker through Sydney Care, technology really holds the promise to the healthcare future of greater access to transparency and data, allowing our healthcare consumers, employers, as well as our providers to make more informed decisions. As we all know, pharmacy costs are a huge driver as well of healthcare costs, and one that has risen significantly over the recent few years. And in an effort to better control those escalating costs for our customers, Anthem created our own pharmacy benefit manager, or PBM, called IngenioRx. We did this to ensure better pricing with our drug manufacturers and to have the ability to better control things like formularies and networks in order to bring financial relief to our customers. We're taking a look at specialty drugs, which can really drive up the cost through our Right Drug, Right Channel program. And we're always evaluating the best specialty drug for the diagnosis and the best place to obtain it. And that may or may not be the lower cost drug. It could be a higher cost drug that we believe and know to have a better efficacy. So this is both a combination of cost and quality and the long-term efficacy for the member. For instance, those members who can safely self-administer receive their medication through the pharmacy benefit program, either retail or mail order. But for members who need to receive their injection or infusion in the presence of a healthcare provider, their medication would be billed through the medical benefit along with their office visit or home visit fees. We're also giving providers real-time data on our members so they can better manage their patients' care, as opposed to historically when they were getting disparate information from us or very little information. So they're getting access to daily reports about members who have been admitted into an ER, the RX drug scripts that have been written for them, opioid scripts when being filled at multiple pharmacies now are evident to a physician who may not have prescribed many or any of those opioid scripts, but other doctors had, and they're getting that information to be able to manage those patients better. So real-time data about their patients is helping our providers to be able to have better insight into patients' care when they're not the one that's actually prescribing that care. So to sort of finalize this, I will just say that COVID-19 is a crisis that has impacted us all directly or indirectly, and it has forever changed how we, providers, payers, and patients, think about delivering access and paying for care. And as I stated earlier, there are many, many learnings coming from this crisis. Much of this current state will become our new norm. And if we embrace some of these learnings, I believe we in Maine can emerge from it even stronger. So thanks very much for the opportunity to speak with you all. I sincerely hope that you and your families all continue to be safe and well during this really challenging time. And with that, I will turn it over to Superintendent Chavez.
Thank you, Denise. And I'd like to thank the Maine Chamber as well and Peter for putting on this forum. It's certainly timely because one thing demonstrates, this crisis has demonstrated the importance of health insurance and access to health care. If you could start the slides, Angie. I'm going to touch on 4 broad topics. An overview of the Maine's private insurance market and talk about two bills that passed last session, LD 2007. Made for Maine Health Care Coverage Act, and LD 2105, an act to protect consumers for surprise emergency medical bills, and also talk a little bit about the Bureau's COVID-19 actions. Next slide, please. I want to give a brief overview of Maine insurance market because it is important and it provides context for the bills I'm going to talk about. One, the fully insured market in Maine is relatively small compared to the total population in Maine. It's a little over 300,000. Maine's population is about 1.3 million. And it's a fragmented market. As you can see, the large group market's by far and away the biggest segment. It's about 200,000. The small group, which is defined as 2 to 50 employees, is the focus of this seminar. And the individual market is just that. It's the individual market at 61,000. And both the small group and the individual market have been shrinking as of late, and I'll discuss some reasons why. Next slide, Angie. And a little bit about rate increases. And this is illustrative. I'm going to talk a little bit about MGERA, the Maine Guaranteed Access Reinsurance Association, and its effect on premiums. But as you can see, in the individual market last year, rates actually went down. And in no small part due to the reinsurance program that I'm going to talk about. Well, unfortunately, in the small group market, rates continue to increase, and they've been increasing year over year at an alarming rate, and it's quickly becoming a non-affordable offering for many small employers, and we're seeing a significant decline in the number of employers who are able to offer coverage to their employees, which is certainly a concern to the Bureau and the administration. Next slide, please. And this shows the average historic rate increases. And a couple of data points I want to point out. If you look at 2013 and 2019 and 2020 data points, you see in those 3 data points, the individual market rate increases have been smaller than the small group market. And one of the reasons, not the only reasons, but one of the reasons is the Maine Guaranteed Access Reinsurance Program, or MGERA. And one of the things that LD 2007 is proposing is there a way to introduce reinsurance to the small group market? So I just want to point out those data points. But as you can see, every year over year, there are increases, and in many years, it's significantly over the CPI for those years. Next slide. One of the things that we're looking at is what's the experience in the small group market compared to the individual market. And when I talk about LD 2007, which passed when we're talking about merging the markets, but one of the analysis we're doing is what is going on in the individual market and what's going on in the small group market. And in 2017, the claims per member per month were 23% lower in the individual market before any adjustment. Well, in 2019, that delta had shrunk to 13% lower. But more importantly and more alarming for small businesses is the last bullet. The trend is much higher in the small group rate, 18.1% over 2 years compared to 5.1% in the individual market. And trend is what's going on with the actual claims, the rate of increase over and above medical costs, what's going on in the individual market and the small group market. So the trend is over 3 times greater in the small group market, which means claims are increasing at a faster rate. And that's got serious implications for the small group market. Next slide, please. But that doesn't tell the whole story. When we adjust the claims for age, geography, benefit, and network differences, we see the differences in the individual market compared to the small group market are different. The average allowed claims in the individual market after adjusting for age was 11% in 2017 and 3% in 2019. That means the small group market is coming closer in terms of the average risk than the individual market. And we're collecting and analyzing this data to see, is there, can we merge in markets? LD 2007, which I'm going to spend considerable time on, will allow us to merge in markets if certain conditions are met, and this is part of that process. Next slide. This slide, I should have started in 2013, which is not shown on this slide. The small group market was over 90,000, had over 90,000 members, and the individual market had 30,000 members. 2014 was the first year of the ACA, of the exchange, and as you can see, the small group market shot up to 64,000, and the individual market shrank from 90,000 to 75,000. But since then, to 2020, the small group market continues to shrink at an alarming rate. And the individual market increased to its peak in 2016 at 87 or 88,000 approximately, but that has been shrinking too, largely off the exchange. And on the exchange, in the individual market, consumers are eligible for something called an advanced premium tax credit. If your household income is between 133% and 400% of poverty, you get something called an advanced premium tax credit, which in effect subsidizes the cost of insurance for those consumers. That market has grown significantly. It's people above 400%. Are largely the ones who are leaving the individual market. And the small group market year over year is showing a significant decrease, and that's a concern, and that's one of the areas we're trying to address in LD 2007. Next slide, Angie. So what's going on in the small group market? One is Denis talked about the underlying healthcare prices. That's driving everything. I don't care if it's a large group, individual group, small group, and even the self-insured market. Most large employers opt to self-insure, and they're not subject to any state mandates, any state laws. But having said that, their costs are increasing the same as the fully insured, and it's the cost of healthcare is driving it. It is critically important we get our arms around the cost of healthcare, because even though there's an MLR requirement, if claims paid in the individual market and small group market if 80 cents of every dollar aren't paid to healthcare, consumers in both markets are eligible for a rebate. But the MLR in Maine is average 85 to 90% in both markets over the last few years. So if we want to address the cost of insurance premiums, we have to address the cost of healthcare prices. Shift in enrollment, a lot of small employers are dropping the coverage, and we're seeing more and more employees going in the individual market. As I said, it's gone from 30,000 up to 80,000, but now it's shrunk back to 65,000. But one of the things that most concerns the Bureau is the deteriorating risk pool in the small group market and the potential for death spiral. And the death spiral is defined as when more and more people drop coverage, we're finding that healthy groups are dropping coverage and going to self-insurance, and those who aren't eligible for self-insurance are staying in the pool, and they're making the economic decision: is it worth the money? Is it worth the investment in premiums to continue coverage? And if you have a lot of claims, you're going to hold on to coverage, and if you don't have claims, you're going to roll the dice. And a death spiral is what the individual market was under pre-ACA, and we're concerned that that's where the small group market is headed. Next slide, please. And finally, the final thing I want to discuss in the small group market is this self-insurance is a viable option for many employers in the small group market. But what we've seen happening over the last few years is more and more employers are self-insuring, which is not a bad option in and of itself. But what self-insurance allows is self-insurers buy something called stop-loss coverage. And stop-loss coverage is just reinsurance for claims above a certain threshold in the self-insured market. Well, it's a good option, but one of the dynamics that exists in the self-insurance market for stop-loss carriers, they can medically underwrite those risks. They can medically underwrite the small employer. So if you have healthy cohort of employees, you can self-insure, you can buy stop-loss coverage. If you have unhealthy employees or employees with significant claims, stop-loss coverage is very expensive or not available at all. Well, the dynamic that creates is in the small group fully insured market, there's something called guaranteed issue. Every employer who wants a policy is entitled to purchase a policy. It's guaranteed issue. Carriers cannot underwrite for health. That's federal law, it's state law. And by and large, it's a good feature. But having said that, stop loss coverage and self-insurance, because stop loss carriers can underwrite for health, the concern is, are they picking off the healthier groups? So the legislature required me to do a rule. And what we did, this rule came into effect, Rule 135. Stop loss carriers can no longer sell to 10 or fewer employers, prohibits exclusions for individual and medical conditions for small employers, and it raised the attachment point from 20,000 to 28,007. And the most recent experience shows there's 411 small groups with stop loss coverage, averaging about 7,600 employees, and the plans had attachment points ranging from 20,000 to 215,000. And again, the Bureau is trying to balance. It's a good option for employers. Employers need options, especially as the escalating costs. And the Bureau's tried to balance the employer's need for options with the requirements in the fully insured market of guaranteed issue. And this is where we're related with 10 or fewer employees, and 20,000 to 28,000, increasing the attachment point to try and strike that balance between guaranteed issue and the fully insured market, but still allowing employers options of self-insuring where appropriate. Because again, it's very difficult for employers and carriers in the fully insured market to compete when they can't underwrite for health in the self-insurance market where they can underwrite for health. Next slide. So what are we trying to do with LD 2007 or Chapter Public Law 653? Again, the governor was very concerned with what's going on with the small group market, and this bill is now law. Was trying to, what can we do to help the small group market? The first thing I talked about, MGERA, Maine Guaranteed Access Reinsurance Association. It authorizes the expansion of MGERA to cover the small group market if the actuarial analysis shows it will benefit both individuals and small groups, and I'll talk about that in a minute. But if it also considers merging the risks of small group and individual markets. Again, the small group market pre-ACA was more than 3 times the size of the individual market. Now, again, the small group market has shrunk dramatically and is now gone from 90,000 to about 50,000 members. And the individual market is about 60,000. So if we merge the market, it'll provide a more stable risk pool, which hopefully will help stabilize rates. But again, one of the conditions that we have to look at when we merge the markets, the individual market and the small group market can be no worse off and have to be better off if we merge the markets. And that's the analysis we're undertaking as we speak. And the third feature of the LD 2007 is it established the ability for the state to go to a state-based marketplace. On the exchange, there's something called a federal marketplace, a state-based marketplace on a federal platform, and a full state-based marketplace. Maine historically has been exclusively on a federal platform. We have now moved to a state-based federal platform, which means we're using the federal government's technology, but the state is going to have more control over the exchange itself, and I'll explain the reasons for that. The next slide. So let me go back to MGERA. MGERA resumed with approval of something called a 1332 state innovation waiver. And I talked about the APTC, Advanced Premium Tax Credit. A 1332 waiver allowed state, it's a function of the federal law, the Obamacare law, and what it allows, if you save the federal government money on the APTC, you can recoup that money through something called this innovation waiver. And what we did by instituting the reinsurance program, reinsurance is very, very effective if you have a small pool in a small state like Maine. If you have few claims, can really drive the cost of insurance. So by introducing reinsurance, it spreads out those high cost claims across a larger population. And we did that by instituting reinstituting MGERA in 2019. We applied for a 1332 waiver, because if we can reduce the cost of claims, and in effect that reduces the cost of premium in the individual market, we could recoup those savings. Because if we reduce the cost of premium, the cost for the federal government goes down in terms of premium subsidies they have to pay, and we were able to recoup that. And it was over $60 million we recouped in 2019, and that reduced the individual market rates by about 7% in 2019, between 4 and 7%. But one of the most important things about LD 2007, The current $4 per member per month assessment sold, that's what funds the reinsurance program. If we expand it to the small group market, we cannot increase assessment, so we have to do it within the current means. If we merge a market, it has to show benefits to both the small group and individual markets, and we cannot increase assessments over the $4 per member per month. And finally, on MGERA, it covers enrollees with 8 high condition costs or claims who have been voluntarily ceded between $47,000 and $77,000. It covers 90% of those costs and 100% to $1 million for 2019. The attachment points aren't really, it's more of an actuarial issue, but the important point is it shows that for high cost claims, the carrier can cede the cost of the high cost claims to the reinsurance pool. But having said that, we get to recoup those reinsurance costs through the 1332 waiver process. The next slide. So if one of the things that LD 2007 allows us to do is to consider merging the individual and small group markets. We're in the process of adopting rules and looking at the 1332 innovation waiver. But one of the things the law says that one of the preconditions for merging markets, it protects that the average premium rates would have to be the same or lower they would have had been absent the provisions of the law. That means when we're looking at this, merging the markets and pursuing a 1332 waiver for the merged markets, will it lower costs or at least maintain costs for the individual and small group markets? Because the overall reason for merging the markets is to provide relief to the small group markets. If you go back, if you think about the slides I had with the rate increases, you could see the impact that reinsurance had on the individual market rates at that time. If we can introduce small group reinsurance to the small group market, especially now that it's down to a size of 50,000, we think it can have a significant effect on premiums in the small group market. But having said that, I have to do an actuarial analysis and have a public hearing in a transparent manner to demonstrate and show that it will save the individual market and the small group market premium dollars at no increased cost. And again, the way we do that, because the small group experience is still a little better than the individual market, the second bullet says the average premium increase is between 2 and 9% in the small group market, and the individual market would see a 1 and 5% decrease. That 2 to 9% increase in the individual market, although it would result in a 5% decrease in the individual market, that 5% decrease in the individual market will result in a reduction in the APTC or the subsidy the federal government has to pay. And it's that reduction that we get to recoup that would mitigate or eliminate the increase in the small group market. And that's what the law allows, LD 2007 allows for. That's what we're going to try and demonstrate. But it's really trying to introduce the concept of reinsurance in the small group market to give them some relief and hopefully reduce the trend from 18% to a more manageable number. Next slide, please. Finally, LD 2007 it's going to look at going to a full state-based marketplace. 11 states in the DC are running their own state-based marketplace. One of the things that LD 2007, again, the governor's mandate was pretty clear. She wanted to help the small business community and premiums they're paying, but she didn't want to increase the cost in doing so. So going to a state-based marketplace cannot assess more in fees than the federal government charges currently, and that's currently 3%. And that's been 3% since the beginning of the ACA in 2014 for FFM or federally facilitated marketplaces. But by going to a state-based federal program, which we're going to in 2020, it's still 3%, but the state gets to keep 5% of the fees, 0.5% of the 3%. And we can use that for advertising, encouraging enrollment, which again, the more people we can enroll in the exchange, the more Mainers are covered, which is a good thing. And the more control we have over advertising enrollment. And one of the examples is, with this COVID-19, the federal government did not open up the exchanges for open enrollment, a special open enrollment, where all the state-based exchanges did open the exchanges for enrollment. And we think that would be advantageous for people losing, who decided they needed coverage during this event. Next slide, please. I just want to spend a very little time on LD 2105 or Public Law Chapter 668. And this is a protection from surprise emergency billings. I'm sure you've heard in the news that care, when people go to the emergency room or get care in general, if they go in network, the Bureau's had several complaints about consumers getting surprise bills. And 2 sessions ago, the legislature passed a bill to prohibit surprise billing and the circumstances where you go to an in-network provider and you get a surprise bill because an out-of-network provider within the provided care. Well, that did not apply to emergency care. And now the legislature passed a bill last session that says if you go to an emergency care, even if it's out of network, because obviously when it's an emergency situation, the last thing you have time to do is do an analysis. If it's the care is in network, you need to get to care as soon as possible. So this bill prevents any balance billing from emergency care, and it holds enrollees harmless. It also introduced something called IDR, or Independent Dispute Resolution, in Maine for emergency care only. But again, it's trying to hold the consumers harmless for emergency surprise billing. The only exception to that is if you knowingly go to an out-of-network provider, if you knowingly elect to obtain the services from an out-of-network provider, but quite frankly, in an emergency care situation, that's not really likely. It does not include ambulance bills, which is a concern. Ambulance bills, typically under Bureau Rule 850, consumers are held harmless because again, in an emergency situation, you have no idea if your ambulance is in network or not, and nor should you even consider that. Well, there is a feature that ambulances we're going to do a stakeholder group to determine how we can encourage ambulance to participate in networks, because we have seen some pretty outrageous bills in ambulances, and that we don't want to become that to become a significant issue that could have a significant impact on rates. So for a year, we're going to meet with stakeholders group to determine ways to encourage ambulance participation in networks. Next slide. So finally, as Denis talked about, COVID-19 really it's unprecedented. This on March 12th, the governor declared a health insurance emergency, which under Maine law gives me broad powers. But the reason for those broad powers is this is unprecedented, and access to care. People shouldn't be losing their coverage and have trouble getting access to care during an emergency, a health insurance emergency. So on March 12th, the day the governor issued her emergency proclamation, we issued an order that screening, testing, and visits for COVID-19 conditions had to be no cost to members. But I have to say, carriers were ahead of us on that. They had almost all instituted that voluntarily. And interestingly, or to their credit, they had also said, gone a step further for COVID-19 treatments. They're going to provide that at no cost to members. They did that voluntarily, and I should recognize that. That was not part of the order. The vaccine, to the extent one becomes available, would be at no cost to members. Network adequacy. We were concerned on March 12th that network providers could be overwhelmed. So we said, if networks are overwhelmed, you have to waive out a network surcharges. If you couldn't go to your provider because the networks are overwhelmed. Early access to prescriptions and prompt communication with providers, members, and the Bureau. On March 19th, we issued an order on credentialing. Credentialing is an important tool for carriers to make sure that the professional staff at the hospitals they're credentialed by them. But we didn't want that to inhibit treatment during a COVID-19 crisis, so we did some things with provider credentialing, allowing hospitals to move providers more freely from one facility to another. Telehealth, again, Denis mentioned that telehealth, they voluntarily had relaxed and enhanced their provisions related to telehealth, but we also ordered that requires rate parity with in-person services. March 17th, Denis talked about this as well. Employers may request health coverage for furloughed workers as long as they pay the premium. And currently under Maine law, if an employee no longer was employed, they were not eligible for coverage. We suspended that law. Then on April 6th, we issued an order that policyholder can upon request a deferral of COVID-19 related to COVID-19 hardship premium deferral. That order is going to expire on June 1st, but that was retroactive to March 12th, I believe. So again, for 3 months, we told carriers that they could not cancel a premium policy for lack of premium payment, and they could not defer. They could not pen claims. In other words, we were still requiring them to pay claims during this process because we did not want employers or consumers to get a bill when they thought they were covered. So that's a little bit what we've done on the health insurance. And just a little bit on the next slide, please. On the property casualty side, and there's just, you know, the COVID-19 is not, even though it's a health insurance emergency, it affected all sorts of insurance. One of the things that has come up is, even though COVID-19 is excluded from a lot of coverages, especially business interruption coverage, we were concerned, and we saw one instance where carriers were trying to redefine or better define their coverage, the language in their policy, and we made it clear you cannot unilaterally during a policy term change the terms of the coverage. If the language is ambiguous or you're going to cover the coverage, you cannot change those policy terms midstream. And you cannot cancel a policy because all of a sudden you thought there's a substantial change in the risk because of COVID-19. We prohibited that as well. Property casualty premium refunds, we issued that, and I'm sure a lot of you have seen and probably experienced auto refunds from personal auto insurers have given back billions of dollars nationwide, and Maine has been no exception. Over 95% of the Maine market has given premiums refund because with the stay-at-home orders, the miles driven had dropped dramatically, and carriers have voluntarily, I did not have the authority to order them, refunded premiums. And the reason for the bulletin, we wanted to make it clear, we wanted to make it easy for carriers to implement those rate refunds, and we suspended rate and form review. You know, we let them implement the premium adjustment and then file it afterwards. Again, we wanted to get the money back into the consumer's hand. And finally, credit scoring. Credit scoring is used in Maine in personal lines for auto insurance. And we wanted to urge the personal lines insurers, you know, this is extraordinary life circumstances caused by COVID-19 to allow consumers to request exemptions from the using credit if their credit score is affected by COVID-19, allow them to recognize, it's asking insurers to recognize not to use credit score in underwriting if the credit score is taking a hit from COVID-19. So I know, and I apologize for going so fast, I covered a lot, but you know, COVID, there's a lot going on both in health insurance. Pre-COVID, COVID has kind of changed our focus for a while, but now we need to get back to implementing LD 2007, which hopefully will have shows promise for relief for small group businesses. And you know, we're beginning that analysis, but I can commit it's going to be done in a transparent manner. And if it would actually cause premiums to increase, again, the law requires me to make a determination that it's got to at least be reduction or at least do no harm. And if not, we'll have to go back to the drawing board on what we can do to help small businesses, because we're very concerned that that market is shrinking and is very close to entering to a death spiral. With that, I'll turn it over to Christine.
Great, thanks, Eric. So I'm just going to do a brief legislative update, talk a little bit about the bills that passed as well as those that have been carried over. I mean, obviously this session didn't go quite according to plan. This was supposed to be a short session. As you may know, the legislature has a long session and then a short session. And typically they adjourn in April, and that is to deal with sort of unfinished business from the first session, as well as any new emergency legislation. So the legislature adjourned on March 17th, about a month early, and obviously they didn't really have the opportunity to anticipate that COVID would create the crisis that it did, that we would be looking at, you know, stay at home or stay safe at home requirements. So they met on the 17th. They stayed pretty much most of the day. A lot of bills that were still in committee and technically hadn't been reported out were reported out and enacted that day. But there are still a lot of bills that remain on the table, either in committee or in the Appropriations Committee. And the anticipation is that they will take them up if they meet again later this year, once things have started to normalize after the COVID-19 situation. So Angie, you can move to the next slide. Some of the enacted bills that deal with health insurance and would affect folks as employers include LD 1928, really was a bill that was intended to address fees that are used in primarily Medicare Part D plans, which are called DIR or direct and indirect remuneration fees. But it also has the potential to affect incentive plans. It basically prohibits retroactive adjustment, which would include paying incentives up front and then reconciling after the fact. So in addition to applying to health insurance carriers and pharmacy benefit managers, it would also apply to multiple employer welfare arrangements, or MIWAs, which are considered carriers under state law. Next slide. LD 1974 was a bill that primarily dealt with telehealth in the Medicaid program, but there is also a provision that says that a health insurance carrier may provide coverage for interpersonal consultations that are conducted by telemedicine, if they choose to do so. So it's not a mandated benefit, but rather permissive authority. LD 1975 is an act to facilitate dental treatment for children, and it basically prohibits the imposition of a waiting period for dental health services other than orthodontic treatment for children under 19 years of age. It will apply to contracts that are issued on or after January 1 of 2021. Questionable as to whether or not this bill was really needed, because today in the marketplace there are plans available both with and without dental waiting periods for children. So, but beginning next year, no dental coverage for children will have a waiting period. Next slide is, the next bill is LD 2096. This is sometimes referred to as cap the copay legislation. So it limits the cost sharing imposed on a member for insulin to $35 per prescription for a 30-day supply. So if someone's taking multiple prescriptions, each prescription has multiple forms of insulin. Each prescription will be subject to $35 for a 30-day supply. That will apply to policies that are issued or renewed on or after January 1 of 2021. It also has a provision that's unrelated to health insurance, but allows emergency dispensing of insulin refills and associated insulin-related supplies, such as test strips, syringes, and that is because it is intended to be sort of a temporary, just get you through till you can get your prescription renewed. There are restrictions on dispensing. It has to be the lesser of a 30-day supply or the smallest available package. And this was emergency legislation, so that emergency refill provision is in effect now. But the provisions that affect your health insurance plans will take effect on January 1, 2021, or your first renewal after that date. Next slide. I won't spend a lot of time on LD 2105 because the superintendent did talk about it. But it does address a gap that previously existed in the surprise billing law. Maine enacted surprise billing legislation, I want to say 3 or 4 years ago, but emergency services were never included in that. So it does address that issue. The next slide expands who can serve as a primary care provider in Maine, beginning 1/1 for your health insurance plans, again for January 1, 2021. Physician assistants can now serve as primary care providers. The law amended the scope of practice and the licensure requirements for physician's assistants. So if they meet those requirements, then they will be able to serve as primary care providers beginning next year. Next slide, Angie, thanks. I won't talk again about LD 2007 because the superintendent did cover that in significant detail. One provision that applies to the benefits that I don't think he touched on is it does authorize the Bureau of Insurance to adopt clear choice plan designs or sort of standardized plan elements that would apply to individual and small group plans beginning in 2022. It also has a requirement that individual and small group plans provide coverage for 3 primary care and 3 behavioral care visits each year. The first primary care and the first behavioral health visit will be covered at 0 cost share. The second and third visits in each category can be subject to co-pays, but not co-insurance, and any copay must accumulate to the member's deductible. So again, that applies to plans. That particular provision around the primary care and behavioral health visits applies to plans that are issued or renewed on or after January 1, 2021. So just to give you a quick sense of some of the bills that were carried over and that will be taken up if the legislature comes back into session later this year. LD 30 was originally a concept draft, and if you're familiar with concept drafts, they usually have no language attached to them. There are 1 or 2 sentences that say this is a concept draft that proposes to do X, Y, or Z. So LD 30 was a concept draft that proposed to improve healthcare data analysis. As amended in committee, it makes some changes to the laws governing the Maine Health Data Organization and establishes them as the state's public health authority for review and evaluation of emergency visit costs. It directs the MHGO to develop and maintain a single source provider database and service locator tool in connection with the Department of Health and Human Services. I believe that they're going to pilot that for the Medicaid program. Next slide. LD 519 is a dental insurance mandate. It would require that health insurance plan include coverage for comprehensive adult dental services. LD 1434 is another provider scope of practice bill. It would allow certified registered nurse anesthetists, I'm not going to repeat that, to bill directly for their services if they are acting within their scope of practice. LD 1611 was an act, or is an act to support universal health care. That is a universal health care coverage bill modeled on legislation that was considered in Minnesota. That is one of there were a whole bunch of single payer universal health care access, Medicaid, Medicare buy-in proposals. So that one was carried over to any next session of the legislature. Next slide, Angie. LD 1995 is a Bureau of Insurance bill that enacts the Maine Insurance Data Security Act. It establishes certain standards for information security programs, some notification requirements that have to be provided to the Bureau of Insurance in the event of an incident. LD 2106 deals with prior authorization for prescription drugs. It will require carriers to have electronic tools available that are capable of integrating with e-prescribing systems and provide sort of real-time benefit information beginning 1/1/22. Finally, LD 2110 is an act to lower healthcare costs. Next slide, please, Angie. That is a bill that came from the Senate President. It creates the Office of Affordable Healthcare within the legislature. They are charged with analyzing data and making recommendations to the legislature on methods to improve the cost efficiency of high quality and provision of high quality healthcare. It would operate under the direction of the legislature's Health Coverage, Insurance, and Financial Services Committee. It would also have an 8-member advisory council comprised of a number of different stakeholders. They would be required to hold an annual public hearing on cost trends no later than October 1 of each year, and would be required to submit an annual report to the legislature. And again, that bill has been carried over and so will be taken up by the legislature when they reconvene. That's all I have. So Peter, if you want to jump in.
Yeah, I guess the first thing I should do is unmute myself here. Our speakers must have done a fabulous job because we have no questions from the audience today. And so we're actually right about on time. I want to thank all of our presenters this morning. It was a very engaging and interesting presentation. I also want to thank our sponsors this morning, particularly Anthem as the premier sponsor. I want to, we're going to see if we can get this up for on our homepage at the Chamber, the presentation, so people would be able to listen in. I'll thank the rest of our sponsors as well: Cross Insurance, Martins Point Healthcare, Maine Health, University of New England, and Northern Light Health. Again, this is the 6th or 7th of these webinars that the Chamber has put on. All of them have been excellent. This one was particularly good. I want to thank our sponsors. I want to thank our presenters. Urge everyone to stay safe, and thank you for joining us today.